Good afternoon, everybody. Welcome to the Royal College of Physicians of Edinburgh. I think some of you may have been here earlier this week for another lecture on how to apply or get into, hopefully, medical school. This is a lecture debate participation on ethics. And the college has been running these sessions on ethics in medicine for about 25 years, for a very long time. And the questions that are asked actually don't get any easier. I've done nearly all the 25 years. And the thing that I've noticed is that the basic principles of ethics are the same. But what's possible in terms of medical intervention, in terms of treatment, drugs available, has changed hugely. And just because we can do something doesn't mean that we should. And so a lot of conundrums, difficult problems come up, and ethics can be at the heart of trying to answer those or treat your patient properly. On top of this too, there's been increased access to information. Some of it is true, some of it is false. There's wide communication between people of ideas and thoughts and discussions which are both informed and sometimes less informed. There have been quite a few of those over the past few weeks to contemplate. I'll ask the panel to introduce themselves shortly, and then we can kick off with a conundrum or two of our own, but would very much like to hear from you of your thoughts and questions that you have. I know that it is quite difficult to go up and speak at meetings like this, but if you do want to speak, there are microphones around the room, and I will point them out if you put your hand up, but you can also communicate via Slido. Now, I understand you've all downloaded an app, or hopefully most of you have downloaded an app, and then if you visit the app.sly.do, and put in Ethics 25, there'll be a place where you can answer questions. They'll come through to me and I will group them and hopefully ask the ones that are most pertinent or most popular first. The last point, say there are no clear right or wrong answers. The whole point is to discuss things, listen to people, listen to what they say, be open to other ideas. And we as a panel, I have to say at the end of these things, always feel that we've learned something too. So at this point, I'd like to hand over to the panel, starting with Kathy, Wojtek, and then Kenneth, and then we'll see whether you have a question or whether we'll be starting the debate. Thank you.
Good afternoon, everybody. Thank you for coming. My name is Kathy Strack and I'm a consultant in acute and general medicine at the Royal Infirmary. So what that means is that I see patients fairly soon after they come into hospital, so pretty much when they come in through the front door, sometimes before they're seen in the emergency department and sometimes after they've been seen in the emergency department. I see all medical problems, so a huge spectrum from falls, heart attacks, strokes, everything. We're sort of like the master of all trades and jack of all trades and the master of none is how I sell myself. In addition to that, I've got a teaching role within the university, so I teach ethics and law to undergraduates and sometimes postgraduates too. And I've been doing this for a number of years, not as many as Angela, but it's always really enlightening for us, and I'm always really impressed at the quality of the questions and the inquiries that we get from you guys. So thank you for coming. I look forward to an exciting session.
Hello, good afternoon. My name is Wojtek. I'm a colleague of Kathy's, but in a very different role at the Royal Infirmary, because I'm a liaison psychiatrist. I'm a psychiatrist who works in a general hospital, seeing patients either who need a mental health contact, who might be in crisis. For example, we every day see patients who have self-harmed or self-poisoned, but also patients where questions of the overlap between mental and physical health are in the foreground. I'm also a clinical director. I help support specialist services in mental health in Lothian, which include the eating disorders service and the perinatal mental health service. Quite often, questions which require a fine balance come up, and questions every day in the Royal Infirmary about one or many and how far we can go to personalised care for one individual versus the many who are waiting. Or questions about when can someone make their own decision in very loaded circumstances where there might be a lot of distress and pressure. And if not, how do we step in? Thank you.
Hello, I'm Kenneth Boyd. I'm a medical ethicist. I taught medical ethics like Kathy in Edinburgh University, and I'm now the editor, one of the editors of the Journal of Medical Ethics. And we in the journal have a category of student essays. And one of the best student essays was from some that I think we've ever published, was from someone at your own stage. So possibly there may be publications in it for some of you in due course. But we'll look forward to what you're going to ask us today, this afternoon. Thank you.
Thank you very much, Kenneth. And I forgot to say I'm a paediatric haematologist, so look after children with blood disorders, but also do some liaison work around the hospital when people's blood goes peculiar because of other diseases they have, although I have to admit I am retired now, but I can still remember a few things. So, does anybody have a question for us from the floor, or perhaps we'll start with one from the panel? Okay, we'll start with one from the panel, but do not be shy about asking questions. We'll be very kind.
We're both being terribly polite. So we thought, just as a kind of starter for 10, we would present perhaps one or two of the challenges that we face in our everyday practice. We don't necessarily have to work through it, but just as a kind of an exemplar of what we do day to day. So one of the challenges that I face as an educator for undergraduates is trying to convince medical students that medical ethics is actually part of our bread and butter. Because I think at medical school, sometimes the temptation is to think of it as these kind of paradigm cases that you read about in textbooks or journals. You know, the Jehovah's Witness who refuses a blood transfusion, the patient with a complex eating disorder who wants to refuse feeding. And whilst these are very important and do happen, they don't necessarily happen every day, and especially to a jobbing doctor like myself. But actually, on my average ward round, I would see maybe sort of 25 to 30 patients, and I can guarantee that for the majority of those patients, there will be an ethical, legal aspect to their care that poses a challenge. It might not be a challenge now because I've got experience in dealing with them, but it might be, there's definitely a dimension. So for example, I'll give you an example from fairly recently. I looked after a lady who has Parkinson's disease, and as part of her Parkinson's disease, she was starting to lose her ability to swallow safely. And as a consequence of that, she came in with a pneumonia because what she was eating was going into her lungs rather than into her stomach. Unfortunately, as part of the pneumonia, she was very confused, she was delirious, and that meant that it was very difficult for her to make any decisions. And we presume that when somebody over the age of 16 walks into a hospital that they have capacity. That's the default position. There's a presumption that everybody we see over 16 has capacity. And the onus is on us to disprove that. For this lady, it was quite evident she didn't. She was very confused. She had a very big family. Unfortunately, there was so many of them that it was not really clear who was in charge, if you like, in the absence of her ability to make her own decisions. And the advice from the team to her family was that she should have a feeding tube put in until her swallow got better. It may get better, it may not get better. We have to treat her infection and see what happens. And her family were absolutely against this. Under no circumstances should you or will you, as a medical team, put in a feeding tube. And that left us at a significant dilemma. What do we do? Because obviously without nutrition, she's going to die. She's certainly not going to get any better. So what do we do? How do we navigate that sort of dilemma? And thankfully, what I can say, and we can work through it, you know, I suspect it will come up as part of the discussions. It raises issues of capacity. So, you know, how do people make their own decisions? What do they need to have to make their own decisions? When they don't have capacity, who makes their decisions for them? And what constitutes benefit? It's very easy for us to say, well, of course it's going to benefit you to be fed. Why wouldn't we? But actually, benefit is about lots more than that. And it actually transpired that she was Italian. She was a matriarch of a very big Italian family where food had always been so important, getting around the table as a family and having a meal together. And she had been very clear to her family that under no circumstance, should it materialise, would she want to be fed. So they were very much her advocates. And it wasn't just about medical benefit, it was about the much broader psychosocial aspects of what constitutes someone's well-being. So that's just a sort of one example of a fairly, not uncommon actually, challenge that we face in the hospital. So I'm happy to take questions about that, or I can move on to Wojtek, who I'm sure has got similarly challenging scenarios.
So perhaps we just take that point a little bit. So as you heard the story unfold, and there was just a little bit more information, then just a little bit more information, I certainly would not say was surprised, but I didn't know what was coming. I think it might be quite helpful to see what you think. Do you have any questions that you'd like to ask? Now, the questions can't be wrong, because they're questions you need to know more information or just understand a little bit more about what's going on. But does anybody have any thoughts or questions they would like to ask? There is one on Slido which isn't directly appropriate for this particular scenario, but does anybody have a thought? At all?
No question is too silly, because actually this is, oh yeah, go for it.
So the easiest way, this is the difficult bit, there will be a microphone sort of to your, there's usually one in the middle. There's one down here, there's one on the wall. If you can bear to go to that one, that's really good, thank you. And you just press the button once and wait, and the light will come on. And then if you can ask your question. Just press it once. Okay?
What was the solution?
Great question. So this is an example of where it's lovely working in a big hospital when you can be part of a team. So I don't work in isolation, I work as part of a team. I have medical colleagues that come with me, but I also have nursing colleagues, I have dietitian colleagues, and I have the lady's GP. So what I had to try and ascertain is, why are the family saying that we shouldn't feed her? Now, obviously, we always assume that people have got the best of intentions. Very occasionally, you come across families who may have slightly nefarious intentions, so you have to try and understand where their views are coming from. So we put that out, we speak to the family, we meet them at length, we might speak to the GP, nursing staff, other allied health professionals that have been involved with this lady's care. The GP had known her for a long time, and you know, the family were very caring. There was no doubt that they had her best interests at heart. So what we actually did was we didn't put a feeding tube in, because it was very clear that's not what she would have wanted. Unfortunately, she had never written her wishes down, which I would strongly advise you all to do. Should you ever lose capacity and you have strong feelings about something in particular, and appoint a power of attorney to be your proxy decision maker should you lose capacity. So we didn't, because her family were very clear this is not what she would have wanted. What we did do when she was a little bit better was do what we call feeding at risk, where we try to allow her to eat, but we mitigate the risks as far as possible by the sort of diet that she has, so kind of thickened stuff that's less likely to go down the wrong way. But the recognition was that her disease, her Parkinson's, was advancing, and she was probably approaching the end of her life. And actually, the last I heard was she'd left hospital and she had flown back to Italy, presumably to spend her final weeks, months, however long she had left there. So, you know, it's a decision that doesn't always sit that well, because I think as doctors, our intuition is to feed. Of course, we're going to nourish people, we're going to get them better, but actually, it's not just about what's going to medically benefit her. You know, if you do not want to have a feeding tube in and someone's sticking a tube down your throat and giving you food through a liquid bag, and that's really not what she wanted then. So we respected her wishes that were expressed through her family and allowed her to feed at risk, and she got out of hospital.
Okay, that sounds like a good outcome. But I think you can sometimes see, you obviously only know one outcome out the one you take, but it may be sometimes that either path actually works out. We just know in this case that the path you took did work out. Okay, so there are no more questions. So there's one on Slido with what would be the best method to overcome a challenge like this. I think we've answered that in this question. So Wojtek, perhaps you would like to introduce one.
Great, thank you. First of all, I might just respond to actually, Kathy, thanks for that example. And as a colleague at the Royal Infirmary in a busy general hospital, it made me think about how ethics in medicine is a practical subject. It walks the corridors. And the question of a person who's confused, who's frail, not eating, might sound not very exciting. And yet we're hearing how really key to someone's sense of autonomy, writing the book of their life, making their own choices, that was. Can you imagine being a doctor or being in the medical team? You've been working all weekend on call. It's been very pressured. Let's say there was another patient who was similar, who in similar circumstances was confused and actually quite inert, inactive. And in a very, very busy ward, people had been putting their food down in front of them. They hadn't eaten anything. And it's only after a couple of days that we realized that person's become dehydrated. They're suffering for being in hospital because we hadn't noticed. These priors can then load that sense of pressure and speed in doctors to feel that they must act. Well, of course we're going to feed her. She's clearly confused. She lacks capacity. It's clearly life-saving. What is there to think about? And to hold this kind of balance of benefit and harm and what is just for that individual requires equipoise that is sometimes hard work. But it guards us against the sort of intolerance that can come with efficiency, because we have to be efficient. We work with a high workload. But because of the decisions that we face, if we don't, in our vocational training, pay equal attention to these kinds of judgments, we're setting ourselves up for a lot of vulnerability as practitioners. We make bad decisions, or there can be abuses of power. Okay? Now, these questions can be quite stark in the area that I work in, where, for example, let's say there was a case, and I have to be careful, it's difficult for doctors to talk about stories from their work without accidentally revealing confidential information. If I say something about a case that was very, very interesting, really challenging from the last week, I might inadvertently, without giving away names, without giving away any of someone's address, I might describe a situation so specific that it could only apply to one person. So as I think of something recent, I would talk to you about something from several years ago, where a young person, older than you, but certainly a lot younger than me, suffering with anorexia nervosa, requests for there to be a cessation of active treatment. That when I next fall ill, or perhaps when I am ill, I am now saying, I don't wish to be treated, even if that means I run the risk of dying. So when somebody is clearly suffering from a disorder, they have a deep-seated fear of eating, of gaining weight, even as they are failing and suffering with decompensation from malnutrition. And as a young person, it evokes very strong feelings in clinicians around them. Yeah. How do we meet that question? Just as a sort of starter for 10, would you consider, how would you think about, can you kind of raise your hand if you think that a person suffering with anorexia nervosa, who can be treated, can regain weight enough to be stable, but it's distressing for them, should they have the right to refuse treatment? Can you think of circumstances like that? So please raise your hand if you think that should be a possibility, or should we always treat people with anorexia nervosa who present with severe malnutrition? So hands up if you think yes for being allowed to refuse treatment. Okay. Thank you. And I can see quite a few hands have gone up. Yeah. Now, what if I tell you that another patient within the last decade is a patient who was acutely unwell. She was in one of our general hospitals on a medical ward, and she was telling the physicians there, please just let me die. Honestly, I've suffered enough. I don't wish for this treatment. Please just let me die. And the physicians there, not working with that specific illness routinely, but also just hearing the patient, were absolutely convinced that she was quite right. Okay? So their view is, actually, we should move to palliation. And I find myself, as the clinical director in that situation, strongly advocating for relevant if you think otherwise. And what kind of information could that be? If a person appears to have capacity, they understand what they are, they understand what treatment is being proposed, and they are refusing it on grounds that evoke our compassion. Yeah. Can you think of any reasons why? What am I going to say to that? If someone's saying, look, I've had this illness for multiple years, each experience of being acutely treated has really, really harmed me in terms of the distress and difficulty it's caused. I'm in the middle of it now. I just can't face it. It's hard. But on the other hand, what I can say is that person, we did have to work through some quite challenging conversation across a gap, across a difference of views. And we had to really hold firm to some evidence of that person being currently unwell, and that current unwellness also impacting on how they were weighing relevant information. That person's now actually living a much more functional life, some full 10 years later. Okay? And I sort of feel like, well, thank goodness. Thank goodness we did not go ahead just then. Does anyone have any questions about that?
Yes, if you could, it's at the front. Be careful, the steps are quite steep and none of us is an orthopaedic surgeon. You just press the button and then let go.
I was just wondering, since you're like a psychiatrist and working with mental illnesses, what does it take for somebody to not have capacity because of their mental illness? So the lady with anorexia or the person with anorexia, would there be a case where anorexia is enough to mean that that person doesn't have capacity? Like, what determines whether someone with a mental illness has capacity or not?
Thank you very much for that excellent question. So firstly, having a mental illness in no way should carry the assumption that you lack capacity. Okay? And I've met patients with, for example, severe mental illness who are actually also, if anything, very, very kind of concrete and logical about certain technical questions of healthcare when they've had a physical health problem. It can, however, also give us some guidance that I must make sure when I'm doing a capacity assessment that I've paid enough attention to this potential area of difficulty in someone's life and how it impacts on their thinking. What most often can arise in, for example, eating disorders, to use this example, is we find that in using and weighing relevant information about some acute medical care, for example, someone's very intense fear of gaining weight means that we can hear in how they're thinking that they sort of can't really think about the risk of dying, because the risk of dying is outweighed very, very clearly by the fear of gaining weight. And when in a conversation with all the relevant information and what's important to the patient and what are the medical facts, when in that we can clearly see that challenge, it then is quite a straightforward capacity assessment. In other circumstances, it's certainly quite common that at first pass, that conversation may not capture that information, and that patient might actually be thought, well, actually, we should always presume someone has capacity. We think you have capacity. So you do need to sometimes know what to probe, what area to look at. At the other end of the extreme, there are famous, we talk case law examples of someone lacking capacity for something that you wouldn't think of as a mental illness at all. Let's say you're afraid of needles. Okay? We're all afraid of something. My daughter's afraid of spiders. Okay? I'm afraid of, gosh, well, lots of things. Yeah? In certain situations, that small grain of something, which is, all of us would agree, you don't see a psychiatrist for that. You might seek some help and an intervention, but it's a very commonplace problem. In certain situations, that could be magnified to become a critical factor in a question of life or death. Okay? So there's a famous case which went to the Court of Protection in England, where somebody who was labouring, whose baby was not progressing, who needed to go to have an emergency caesarean section, and pretty soon, and who was saying, yes, I want the baby to be delivered, please do that, was then finding that as they tried to take her to theatre, repeatedly, she would become overwhelmed and say, no, 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 stop, 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 I can't do it. And the underlying reason there was that, in fact, she was needle phobic, and she knew that when asked the question, do you want your baby to be delivered safely and be healthy? The question was a resounding yes. But when the practical aspects of that came to the fore, of having needles, of having a Venflon, she would then be overwhelmed by fear, and at that moment lost capacity. So that's an example of the other end of the scale, where that person lacked capacity. They were then given sort of legal protection overall to have that procedure carried out, knowing she would not be able to capacitously consent to it in that moment. Okay? And yet the difficulty causing her to lose capacity is not a major mental illness. It's not something that you'd be seeing a psychiatrist about. Okay? Although, of course, you can have CBT. Does that answer your question?
Thank you very much, Wojtek. I know I've left Ken out because I think you had a few comments about the first case, and I'm sure you have a few comments about the second as well.
Well, really about both of these cases. What you've been hearing is what doctors call clinical judgment. But clinical judgment, it's how you weigh up in different circumstances things that are pulling in different directions. And sometimes people think that ethics is just about what's right and wrong in any different circumstance. But ethics actually is not about that. Ethics is about judgment, and judges do it in courts of law. Doctors do it in their profession. We all do it to some extent, and the best illustration I can think of what's involved is if you think of, way back in history, and a man steering a boat in a storm in the Mediterranean in the dark night. But there's enough for him to see the stars, and the stars, and he's had enough experience to know the noise of the waves and the wind, and he can use his judgment in that circumstance, bringing all these things together to try and get the safest way home to port. But he may not succeed. Judgment is not infallible, and that's one of the difficulties doctors, I think, have. That those of us who are not doctors often think, oh, doctors. I mean, I remember a stage in my life when I thought psychiatrists were like people with X-ray eyes. They knew what you were thinking, but they don't. They have to ask questions and all sorts of things like that. But that's the kind of judgment we all have to do. There are the stars are the sort of ethical principles: preserve life, avoid harm, do good. But as in the case of the ones you've just been talking about, you've got conflicting things, and you've got to try and never make the decision on your own. And beyond all that, I would say, there's an old, I think it's probably a rather risky song. It's not what you do, it's the way that you do it. But that is very important too. How, a lot of ethical questions are not about what you do, it's about how you do it. And I think we've had good illustrations in both of these cases of how doctors work towards a solution, never infallibly, but they do the best they can in the circumstance. At least most of them do. So there we are. That's what ethics is about, I think.
Now, picking up on Professor Boyd's comments, he was just saying how we're taught that our ethical training is sort of like learning how to navigate by the stars. That we can't reach the stars, but they kind of give us that direction to go in, that kind of compass bearing. But if you go to different parts of the world, actually the constellations look different in the sky. So if I go south of the equator, it's all a bit disorientating. Now we doctors, as we navigate changes in society and culture, can then also feel disorientated by now we find ourselves somewhere where the stars do look like they're slightly different, they're in slightly different places. And one of those questions, which I'd be keen to put to you, is what do we as doctors have by way of a duty of care or a public health responsibility to contribute to the conversation in society about health beliefs? What's healthy, what's harmful? Now that we know even more powerfully than before that we are not the only base, that there are many, many places on the internet where you can read and watch really engaging material that might say vaccines are bad. If you have cancer, don't take the treatments. For us as doctors, it's a difficult thing to see somebody we are very worried about. They have an acute health problem, and yet we find that it's hard to reach them. We speak across a gap because they also have access to somewhere where they feel safe, where they feel that they hear advice they trust, which is in direct opposition to us. Now, those persons are usually, they're capacitous, they are not confused, but we can say there's also what the doctors might patronizingly think of as a layer of vulnerability because they're really, really connected to these spaces which offer them advice that we would disagree with. Now, do you think, raise your hand, do we think, we as doctors, should we be setting up workshops? Should we be trying to learn how to do more in social media, to be engaging, to build spaces that people can come to and feel comfortable with and trust, but which then offer kind of, the medical advice that we have evidence for? Do you think that's a role for us? Or if we've only got so much funding in the NHS, is it enough to say, well, we've offered you this treatment for cancer, you've rejected it, that's your decision and goodbye? What do you think? Hands up if you think we should be funding some sort of initiative to help with this. And if you've put your hand up, then you're speaking to someone who is not, who's pre-digital. I'm a dinosaur. I'd be really keen to hear your view. And what could that look like? What would that be? Or have you come across an example where you think that would be important?
So, Wojciech, can I just say, so there is an NHS site which gives the sort of the NHS view, and obviously the NHS practice in England and Wales is, because we do have, I think, about a couple of hundred people online as well who come from all around the country. What happens in England and Wales is different from Scotland, but that is a resource available. But if you type something in, you sometimes get American sites just pop up. So it depends whether your background knowledge of how likely that is to be directly referable to what you want to know, or should you stick with the NHS site? So there are some things out there.
There are some things out there, and I guess I'd be keen to hear from the audience about, there's information there. There's something much more engaging and much more tribal about stories in the sort of Instagram space and TikTok. And I meet with patients who have very clear long-term conditions where they choose to reject NHS care or advised treatments, and they've spent tens of thousands of pounds pursuing what to me sound like very exotic and clearly non-evidence-based treatments based upon beliefs that I disagree with. And what is my role there if I continue to see that patient, for example? Am I colluding with them? Or if I try and sit with them and when those treatments haven't worked, point out to them, look, I'm not sure. Rather than saying, look, these were the facts, they remain the facts, you're wrong. I kind of say, look, I respect that to you this is very important, but I grow worried that I'm not sure if this has been benefiting you. What do you think? And by this kind of adversarial collaboration where we have differences of view, and I could just get cross and tell them, look, if you reject this, go away.
But where would you look? You guys out there, where would you look? Would you go to Instagram? Would you go to your friends? Sorry to cut you. Would you go to TikTok? So who would go to friends first? Friends that you sort of know and think might be able to understand your problem. Who might ask friends? Well, I'm not going to ask you to tell me why you would ask your friends. I just wondered, would you go to friends? Would you go to Instagram? Would you go to random Googling? Is that random Googling? Does anybody want to say, or you can shout out? If you can shout out all together, we can see if we can hear what the strongest thing. Shout out whether it be friends, TikTok, Instagram, Google. What would you do? Okay, do it in 3, and you better be some noise, otherwise I should be upset. So 1, 2, 3. Okay, so I heard Google and TikTok. So it's a variety of platforms. Okay. So it's a variety of platforms, and Would you do something that we call triangulation? Would you cross-reference? So if you got one answer from Instagram, if it was the same as yours, would you say, great, that's it, that's the right answer? Would you say, oh, I wonder if TikTok or Google has something slightly different? Because that's the whole point. That's what I think what Wojtek's trying to get across is it's very easy. If you find a couple of people, I think it's 12, that think the same as you, that is enough for you to know that you are right. And so it really depends where you look for your information, and sometimes it's really just to confirm that what you think is correct. Yeah, please, shut me up.
If you find 12 people who think the same as you, you're right. All right, you're onto a fascist website. That's the problem.
Quite possibly, but it is the idea that if you find...
I'm not suggesting you're a fascist,
No,
but I think that's one of the problems, isn't
Yeah.
it, about media, that people get into what they call their own silos.
Yeah.
And I would add that the challenge of feeling ill is that we're all looking for a space where we feel safe. You want to be in a space where everybody agrees with you, or if there's a space you already trust, that's where you want to be. So I'd also not be, I always try and hear earnestly somebody else's views in these situations, even if they're actually, very, very opposed to my own understanding of medicine and health. But it's a challenge because if I were to be brisk and efficient, I can say to somebody, look, I respect your views, but they're wrong. That person's not going to come back and see me. Equally, if I see them 5 more times, I'm using up time I could be using to see other patients. But to try and see if we can build a collaboration, I think that's another question, which is an ethical question today. It is about speaking across difference. So actually, there was an interesting paper recently in your journal, Kenneth, about adversarial collaboration, and also that question of rationing in a health service which, as you hear, is under pressure.
So that actually brings us very neatly to a question that a few people have ticked on Slido. Perhaps we should go to that. I think they've mentioned Jess's rule. I think it probably mean Martha's rule. But recently we've had Martha's rule introduced. Do you think Martha's rule empowers patients by ensuring their concerns are heard, or might it risk undermining GPs or perhaps other doctors' clinical judgment? Now, we know from a pre-conversation that Kenneth's read this paper recently.
Well, I haven't read a paper, but I've read a long article in this week's London Review books by Martha's father, and about the obstructions that he encountered in that particular case, and how this all came out of that.
So do you want to say what Martha's rule is?
Martha's rule was that if Martha had sepsis and they didn't catch it in time and she died. She's a 13-year-old girl, and there was a lot of miscommunication, as far as I can gather, that went on between different people, and particularly with the family. And so the rule is that they should families' worries and questions should be attended to and given space to. That's right? That's more or less what it says. So again, it's the how and that's so important, and you can produce suggestions like Martha's rule that say. Remember, because doctors haven't got a lot of time, as you're pointing out. So to have a quick rule of thumb in that sort of circumstances, do that can be helpful. I mean, it can also be not unhelpful, but it can be helpful, and that's what this issue of Martha's rule is about.
So yes, I think it's if you are worried that you yourself or your one of your relatives is getting worse or not being treated properly, you are allowed to challenge that.
Exactly.
And it can be very daunting to do that. I don't know, Kathy, have you got some experience of that or thoughts?
So I think it's easy to see how it can happen. And that's a terrible indictment of our NHS, but it's true. So, obviously I don't work in paediatric services, but within the adult sector, wards are busy, teams are operating a different way. When we were training, it was very much the firm. You were on a firm, you had the same consultant, registrar, other colleagues, and you worked in that firm and you stayed in that firm. That's all changed. We often work in teams, there's shift changes, and it's easy to see how communication can become lost. But that said, there are lots of robust systems around early warning scores, particularly in the context of sepsis. So one would hope that families never have to raise concerns, that there would be enough clinical acumen, that there would be enough safety netting, enough safeguards in place that we would recognise when someone is sick. But clearly that isn't, sadly, always the case, clearly from what we've just heard. But I think there is a change in culture. I think when I started as a junior doctor, I think paternalism was quite rife, and it was very much whatever you think, doctor knows best. And sometimes very much if you ask the older generation, and not exclusively, but often if you ask them to say whatever you think, doctor. Whereas younger patients, I think, are much more empowered to challenge us. And that's entirely appropriate. I think we should be challenged, and I'm more than happy for patients and their families to come and challenge us. And I think we would want them to, because we know our systems are not perfect. We shouldn't rely on families raising concerns, but clearly sometimes they have to. And the fact they're not listened to, I think, is terrible. I think sometimes we need to make sure we've developed a culture where not only staff can speak up safely without fear of reprisals, but families can too, and make it easy for them to do that in a way that they're going to be listened to. I think sometimes families that repeatedly raise concerns, sometimes people might think, oh, it's that family again, and that's not what we want to happen. We want to make sure that there is in the same way that there's a clear route for staff escalating concerns, that there's a clear route for patients. And I think sometimes we're not always the best at when patients land in the hospital, they're messy environments, it's really hard sometimes for patients to navigate the system. Who do I talk to? Who's in charge of the ward? And I think we have a role to play in making that better, making it easy for people to raise concerns. And as healthcare practitioners, we have a duty to listen to them. And I think, woe betide anybody doesn't listen to a concerned family member, frankly.
Thank you very much. Do people feel reassured that Martha's Law is now being passed? That it's okay to ask, what are you doing? Do you think you're doing the best? Would like a second opinion. Does anybody think that's not a good thing to have passed? Okay, that's good. So I think that everybody's pleased to see that. So perhaps I go on to a question. It does come back to something that Wojtek said about the needle phobia, but 12 people have liked this question. So in cases where a pregnant patient refuses a C-section, so a caesarean section, that could save the baby, whose rights should take precedence? The mother's autonomy or the unborn child's potential life? Now, none of us is an obstetrician. Ken, do you want to kick us off? Or shall we start with the...
Let's have the clinical view.
Let's have the clinical view first. So it's actually perhaps Kathy first and then Wojtek.
Difficult. So I think if the woman has got as far as discussing a C-section, then clearly this is a pregnancy that the woman is prepared to take to full term. So assuming that she has had the opportunity to terminate that pregnancy along the way, should she have wanted to, the fact that it's got this far, and then if there, for whatever reason, there is a phobia around what happens next, you would that's clearly, as Wojtek was describing earlier with the case of the needle phobia, there's a mismatch between what somebody desires and what they're saying in that moment. And I guess it comes down to whether what they are saying in the moment is so consuming that it's actually outweighing and enveloping their desire, which is to have a healthy baby. And obstetricians, I suspect, navigate these decisions probably not uncommonly, but one would hope that somewhere along the line of antenatal care that those things would have been addressed, but clearly not always. Was that the question, Angela? Sorry, it was around needle phobia.
Yes, it was just whether at that stage where the mum's about to have a C-section, if she doesn't have it, the baby may die. And would the baby's health take precedence at that stage over the mother's fear of not having a C-section? Oh, yes, fear of having a C-section.
So I suppose in that situation, the fetus has no rights. So legally, that is the status of a fetus, that it has no legal rights. Whereas obviously you have a woman, a capacitous person who does have rights. So legally, the woman's health, right to life, does trump the fetus's. But it would very much depend, I guess, on why she's saying what she is saying. What you want are two healthy individuals at the end of it, two heartbeats. Legally, it's the woman's who would trump, but I think it would very much depend on why she's saying what she's saying, and is this actually, as Wojtek was describing earlier, a mental disorder that you can then say, well, actually, that's affecting her capacity and her ability to make a decision, ergo we can intervene here to try and ensure there's a good outcome for her and the baby that presumably is desired.
Just to come on to that as well, it's an excellent question, and one which illustrates really nicely what immediately sounds very complicated, very difficult on the one hand, and also we need some more information. Yeah? I wonder about what's happening. Why is a person not wishing to go ahead with a caesarean section? Legally, your position might be clear, but I also just want to understand the situation, and so doctors will know to rapidly communicate with others, to share their concern about a situation like that, and try and gather more information. One example I can think of is the person saying, well, you know, I plan not to have a caesarean section. I'm told there's now this complication and it's necessary. But let's just say my sister had a caesarean section and she developed some sort of rare complication and infection and she died. And I'm told that's very rare, but I cannot shake off the feeling that my way of carrying forward, you know, her memory and so on is to make sure I never have a caesarean myself, even if that means that I risk losing my pregnancy and, you know, hopefully have the opportunity to try again. Okay? If we hear a story like that, for example, would that change the clinical thinking? Would that change how clinicians approach that situation, or at least their own dissonance about, oh, but it could be so straightforward? And in my experience, I think so it does, and it helps us kind of communicate with the human story. It reassures us that we understand there is a heavy burden of something weighing on this person, and that's why they're making this decision that we might not immediately have arrived at ourselves.
Thank you. Kenneth, do you want to?
Yeah, there are things that are known as tragic conflicts when there is no absolutely right answer, and you have to come down on one side or another. And I think the whole business of the status of the fetus is a very difficult, because people have very strong, often religious views on this, and they become polarized. I think they were less polarized from the past, and so that makes it very difficult, because people's religious or political views are very much tied up with their own identity. You know, it's part of me, what I think about religion or politics, and so whether I'm for or against it. And so people can get very, can focus on what's right in this situation according to my view. Whereas the doctor, I think, is trying to say, how many patients have I here? And I think that's a more sensitive way of dealing with it. But it's not one, obviously in our society, it's not one that you can expect everybody to share. So it is a very difficult area.
Thank you very much. It does lead us on to another question, which has been liked by 10 people. As a doctor, should someone's religious beliefs matter more than their own health? So you've just touched upon that.
Should someone's
Religious beliefs matter more than their own health?
I think for a doctor, you have to stand back from your own personal religious or political, just strong political views. And there are areas, I mean, for example, if doctors have got strong religious objections to abortion, they can refer, a GP could refer to another GP. It would probably be unwise for someone with that view to go into gynecology, because it wouldn't be, you'd be confronting the dilemmas all the time. And there must be other areas as well, but that's really the one that's most obvious. It'll arise also if euthanasia is legalized. The same sort of issue will crop up there. I think the general view has been that if you're directly involved, if you're a doctor who's treating a patient, you should do what is primarily do what is in the patient's best interest. You should try to avoid getting into a situation or a specialty that would involve conflict. But if you're, say, a medical secretary, it's a bit more difficult. And the law, I think, is more saying, well, perhaps you should, if you object to writing a letter, a referral letter, that might. I'm not quite sure where the law is actually on that at the moment. I think it may be case dependent on cases. But yes, I think you're primarily, and I would have thought it's a religious, and my understanding, it's also a religious view to put your patient's view first, to love your neighbour as yourself, for example, which is a common to all sorts of, or to do, all religions would hold, do to others as you would have do to yourself. So, but I think practitioners probably would say more about this than I'm talking theoretically, you're talking practically.
I think picking up on that, and I heard that question in a different way, where it's just to really emphasise that agency and personhood, our right to be a person, including our stable, for example, religious beliefs, absolutely trump our health. It's absolutely correct that you may choose to make a decision which is bad for your health, but is in step with who you are, what your choices and preferences are, what you believe in. The archetypal case, of course, that we're taught in medical school is being a Jehovah's Witness, and therefore having to refuse blood transfusion when that's offered, because you're not allowed to, in that faith, to accept blood products. But I remember one case where I was referred to someone who, there was a situation where someone was refusing on the grounds that they were a Jehovah's Witness. But getting into the detail, just think about, well, how long have you been a practitioner, a member of a church? And what we eventually got down to, this isn't somebody who'd been of that faith for the past 20 years. This was somebody who was actually acutely psychotic and thought themselves to be actually a religious figure themselves, and they thought that they were in the Jehovah's Witness faith, but they'd only had those views and those thoughts for the last few days. So that would be a rare situation, which actually prompted us checking our assumptions. Even though that sounds like the textbook entry of, oh, you're a Jehovah's Witness, okay, tick, therefore refusing. Actually, there was something more complicated there. So it delves always in the detail. But agency, personhood, your right to make decisions, even if they're contrary to your health, is absolutely your right. In the same way that my own personal beliefs have no place in my role as a doctor and my professional conduct. Another point about that is part of all this training and the ethical training is being professional does not mean not having feelings. Being professional means monitoring one's feelings, being in touch with them. If I meet somebody who's got very different beliefs to my own, or is very offensive to me, if that starts to penetrate and I start to feel angry, actually a little red light comes on for me to say, Wojtek, be wary here, slow down. Do you have to sort of postpone a decision? Because I know that if I'm starting to get emotional in a kind of, in a way that beyond the normal, that's not going to be compatible with good clinical decision making. Yeah? So it's by being in touch with my own feelings that I also make sure that I continue to carry decisions with equipoise. And I don't make decisions when I'm angry. I'm not saying I get angry very often. Does that help?
Yes, thank you. But taking it again from a slightly different perspective, so as a paediatric haematologist, the children I looked after often required blood transfusions. And so we had to have a very specific policy about that because the parents would give consent for the child to have the transfusion. And it would seem simple. So a child requires blood transfusion, otherwise they'll die. The parent says, I'm a Jehovah's Witness and I will not allow my child to have that transfusion. The only way one can actually legally give the blood is to make the child a ward of court, which can be done quite quickly, although it is difficult in itself to do. But then you need to explore how the parent will treat the child who has had that blood transfusion, because sometimes they can reject them. So because they have had a transfusion which is against their religion. So it's something sometimes really difficult to think about. And sometimes you can't empathise. It slightly irritates me sometimes. It's on the instructor. You must empathise with your patient. sometimes you just can't. You cannot imagine yourself in that position. You cannot imagine yourself thinking like that. And like Wojciech, you know, you have to say, look, what can I do in the best interest of the whole family, of the particular child? So the question about religious beliefs and can a patient put their religious beliefs ahead of their health, the answer is yes, they can. If it becomes their child, it's a whole different story, which we haven't quite got time to go into. But I think hopefully you can see that ethics grows a bit like a mushroom. You can't learn it in isolation. It evolves. You need experience, you need knowledge, you need people, and you need time and recognition within yourself to say that actually this is a very difficult problem.
There's a short saying that you're entitled to become a martyr, but you're not entitled to make a martyr of anyone else,
Yes, I think
including your children.
exactly. So I will move on, actually. There's another really interesting question. There are lots of really interesting questions here, but we do have to finish at 6, so that's a shame. So in the situation where two patients are in equally critical condition, but one is complying with medical advice and one is refusing care or perhaps not complying with medical advice, which patient should be prioritised? So Kathy, this is you.
Well, what an interesting question. So I'm going to change the premise of the question slightly and then I will answer the question. So I guess where you've got two patients competing for treatments, this was something that we wrestled with during the pandemic. Obviously, we were concerned that this situation could arise. We were fortunate, if I can use that expression, here in Edinburgh compared to some places in England where intensive cares were overwhelmed. Yes, it was very difficult, very traumatic for teams up here, but I think we were perhaps not in the situation of having to consider rationing in the same way that perhaps some other units did. And I suppose when it comes down to it, you know, if you've got two patients competing for the same treatments, the question is, who is going to benefit most from that treatment? If you've got a scarce resource and you can only use it for one person, then ultimately, if you are, you know, adopting quite a utilitarian perspective, then who is going to benefit the most from that particular resource? The challenge is if somebody is not complying, if you like, with the treatment, somebody is, your instinct is to say, well, if you don't want the treatment, then we'll give it to the person that does want the treatment. But I suppose it comes back to why is that person not complying with the treatment? Is it because they don't fully understand what is involved? And you'd be quite surprised. What do you think the average reading age for Scotland is? Anybody shout out a number? What age do you think? For Edinburgh and the Lothians? Yeah? Hands up if you think, I'm going to pluck a number, 15 or above. Under 15? Okay. Under 10? Okay, it's 8. So, which is quite staggering, isn't it? That so when you're thinking about, and obviously that's broad, we're talking about, you know, averages. But it's actually, sometimes it catches you out, because often, not often, but I have been in situations where patients have refused a treatment, and you can't really understand why they've refused the treatment, but actually it's because they haven't understood. And, you know, perhaps the way that the information has been presented has not been presented in a way that is easy to understand. And it's quite, you know, sobering to think, well, you know, my eldest son would be able to understand this in the way that the average person is. That's quite brings you up quite starkly. So I suppose that the point is that why are they not complying? Is it because they don't understand? Is it because they don't trust the doctors? Or is it genuinely that they don't want it? If they genuinely don't want it and you have done all that you can to try and determine that they've got capacity for that particular decision, then obviously if they don't want it, then is it presumably their person that the treatment? But we have to be very careful, this issue of compliance, because people don't comply, and I don't really like that term, but that effectively, I suppose that's what people are doing or not doing is why. Because, I think particularly the assumption is that people always understand what we're telling them. And I don't mean that to sound patronising or paternalistic, but, I sometimes have to pull myself up when you use jargon, that actually not everybody's necessarily going to understand. And people do have different health beliefs. They may not believe what they're saying, they may not trust us. And because somebody makes an unwise decision, it doesn't necessarily mean they don't have capacity. It might just mean that they have slightly unusual beliefs that we should respect. But not everybody is always going to want our treatment. That was a very circuitous way of answering the question, but it's also hopefully brought in some other ethical themes and challenges along the way.
Kenneth Wojciech?
Yeah, I mean, apart from the... Sorry, I think most people have... Doctors spend their whole time in a medical environment, or most of their time. This is often the first time someone, especially coming in to A&E or some sudden thing, it's very bewildering for most people. I mean, they haven't had experiences before. A lot of things are happening around them, and it does mean that you have to be patient and explain and try and communicate with people with very different backgrounds, very different educational understanding, and probably fixed views of what happened to Auntie Jean. You know, I mean, that
So just while I remember, because otherwise I'll forget. So when you get a medicine, in the packet there's something called the PIL, the Patient Information Leaflet, which if any of you have even looked at it for something like paracetamol, it goes on forever in tiny writing. And one way of trying to improve the information about medicines that you take is to actually ensure that there are videos, TikTok, things that you can watch rather than reading this very fine print. And that's something that's coming in, not quite yet for many things, but it's beginning to start, because communication of what really needs to be known is becoming much, well, not more of a priority, but it's been realised that just giving people a leaflet with the information on is not enough.
Thanks. I think 2 quick points. I was just thinking of this question of who do we choose and ration care. That was such a powerful and loaded question for us during COVID. But there are also services working every day who are perhaps in that situation quite a lot. And one example of that is a transplantation service. So a couple of my colleagues work with teams doing liver transplants, renal transplants, and the question of if we use very, very precious resources, so someone has died and they've given their liver, who stands to benefit the most if we have a list of patients with liver disease, and can you help us make sure we make the best decision possible? So if you imagine doing a psychological assessment of who can look after a liver the best, how do we approach that? And is it somebody who looks like they come from a nice settled household and are very polite versus somebody who's kind of rude and a bit obnoxious? Would that be the right way to do it? Or is it to examine someone's habits, strengths and resiliences, and are they likely to be able to take medications regularly? If they're currently involved in some harmful habits, can they try and work and demonstrate some change around those? Yeah. And as Kathy was saying, it isn't about the kind of conflict now, it's about trying to take a cool and level view of giving the opportunity to the person to demonstrate changes and thinking about how they might benefit into the future. So that's one example. The other one, I think, is just reflecting on real clinical practice. And when we are working with a lot of challenge, and a patient has been unwell, and they've been behaving really, really challenging, there's a lot of kind of pressure in the system, we start to feel overwhelmed as clinicians, just being normal, ordinary, frail human beings. And when we do that, we can start to kind of forecast in a catastrophic way. This is very difficult now. This will remain very difficult far into the future. And for that reason, we feel very pessimistic. But quite regularly, those situations turn out to be, for example, someone with a really challenging experience of delirium in the hospital, where just a week later, they might be saying, I thought I was in a prison and you were torturing me and there were aliens landing on the roof. They had such an aberrant experience, which at the time was quite overwhelming to us as clinicians, and yet turns out to be transient, treatable. And for these reasons, we studiously take care not to, when we are thinking about different patients and how they benefit from care, not to make assumptions about the present challenges that they might present with.
Thank you very much. And just to say that when you do start in medicine, you don't have to make these decisions all by yourself. In fact, you're not, in a way, you're not encouraged to do it at all. But it's really important that you understand that these decisions are there to be made and that there are people there who have a lot more experience and so on to help talk through and make these decisions with you. We haven't actually touched on consent, and there's quite a popular question, the next one down, is if a patient consents to treatment because of family pressure, can it be considered truly informed consent? And another question which is similar, if a patient who is of the legal age to make their own judgment for treatment refuses treatment, yet their parents wish for them to have treatment, whose decision would the doctor take? So we're talking really about consent, informed consent, and whose consent is most important, perhaps. Actually, as Wojciech's just spoken, Ken, do you want me to lead with that side?
Yeah, I'd be interested to get the actual Kathy's view on this, because the practical view of getting consent. Yeah, sorry.
So for consent to be valid, there needs to be three things. So first of all, it needs to be sufficiently informed. That goes without saying. And some of you might recall the Montgomery case a number of years ago, where it was ruled that actually the lady hadn't been given sufficient information, and had she been given different information, she would have pursued a different course of action. So, there's lots and lots around about how much information is important for somebody to have. So informed consent, it needs to be free from coercion, and I think that's what the question is alluding to. And that can be really difficult. And similar to what we were saying before, somebody over 16 comes into hospital, you presume they have capacity, and capacity is obviously the last bit of consent. So enough information, free from coercion, and you've got to have the capacity to make a decision. And it can be quite hard to determine whether somebody's being coerced or not. And, lots of I'm not a surgeon, so we don't get consent for operations, but, we do need consent for lots of what we do in hospitals. Scans, putting cannulas in, procedures, for example. And sometimes people do defer to their families. Particularly elderly people might say, oh, we'll speak to my daughter or speak to my son. Is that coercion, or is that supported decision making? So I think if somebody is over 16 and you think they've got capacity, you take the decision at face value. But you do have to be alert to the fact that sometimes coercive forces can be at play, and sometimes they can be quite subtle and difficult to unpack. And again, that's where it's really helpful when you work as part of a team, and the nurses might pull you aside and say, oh, do you know what? I'm not quite sure about this person's family member. They seem to be applying a bit of pressure for decision X, Y, and Z. And one scenario where I see this, perhaps have seen this, is around discharges and discharges to care homes, for example. So perhaps an elderly person who's come in with a fall and really, really wants to go home and has capacity to make their own decision about that. But we all recognise that it's going to be a bit precarious, at risk of falling again, but they really want to try. You can support as much as possible with a care package and various safety netting, but the family member says, no, I think we need to relook at a care home now. And then the narrative starts to change slightly, and before you know it, people have started, exploring those options and need to hang on, try and wind it back. And always remember that the patient is you only have one patient. When you come to children, obviously you don't. You've got, at least 2 or 3, or sometimes maybe even more. But if somebody is over 16 and they refuse treatment and the parents are saying something different, then it is the patient's wishes that trump, not the parents. But that can be difficult to navigate. The grey areas where patients are under 16 but perhaps are competent, and Angela can probably talk to this a bit more, but something that we call Gillick competence. So children, minors, let's say, maybe under 16, but may have enough capacity to make a particular decision. The challenge is, if the parents disagree with that decision, what happens? And a lot of these cases end up in courts, particularly when it comes to treatment refusals, where the stakes are high, and there have been sort of, hematological malignancy cases where that's happened. So I suppose, the bottom line is we have to be alert to coercion, because, consent is not valid if there is coercion at play, but it can be difficult to unpack, and that's where it's helpful to be part of a team. But, parents obviously have views, of course they do, but if you're over 16, and perhaps even if you're less than 16 but are competent enough, the parents' views may not be able to trump that of the individual.
Going back to what Kathy was saying about the Montgomery ruling and when is consent sufficiently informed, I was just thinking of a case where, well, it wasn't a case actually, it was a debate. We organised a debate at the medical school about the Montgomery ruling. And in the questions and the discussion with the audience, a member of the public who'd attended shared her story. And her story was, well, I had breast cancer and I was treated for it. The doctor explained to me some of the side effects of a medication called tamoxifen, which I then took. The doctor didn't sort of find out enough about what I do, what's important to me, and they didn't mention a kind of rare side effect of tamoxifen, which was dysphonia. It can change your voice. And actually, I was an opera singer. And so then my voice changed. And if I'd known that that was a potential side effect, I would not have had that treatment, because that's very, very important to me. And that's one of the challenges of informed consent, of that sliding scale of really trying to personalize consent giving enough, giving people enough information. On the other hand, not blinding them with science, with sort of 25 pages of potential side effects that have happened a few times in the world. And yet we must strike a balance, and we must lean into that act of personalizing it enough. As a psychiatrist, some of interesting kind of situations and complicated situations that arise with regards to consent, and a kind of also but maybe a push for treatment and intervention, is when rarely we see in hospital what's called factitious disorder by proxy. So someone might come to hospital with some symptoms, maybe some signs of illness, and they have a partner or someone from their life who's with them, and appears to be driving things forward, appears to be insisting upon interventions which are not risk-free, like surgery, and where we then have to proceed very slow and very carefully to try and unpick what that situation is. That usually results in us calling, as we've heard in other examples, some sort of meeting with our other professionals. We might use the vulnerable adults kind of meeting framework to meet with social workers, police and others to try and just gather information. But we slow down when it gets complicated to try and unpick these challenges. On the other hand, I'd also just make a brief reference to the fact that we don't all come from the same place. And one thing which I kind of found initially a bit daunting when I was younger and a trainee was how a lot of people in the world come from a place where culture is a lot more collective. And for them, it is normal to consult widely with a family group before coming to their own point of view. That's not the same as undue influence from some individual. And someone's going into a clinic to be faced with 8 people who wish to also be in on the consultation would initially feel a bit daunting. I'm going to be swamped. And yet what I very often found was that embracing that actually really helped with the process, because that family group, some of those relatives would then actually hold that information very, very well and be able to discuss it more with the patient after the appointment. So I kind of learned to embrace it rather than fear it. But that's just a kind of comment, that sliding scale between individualism and collective ideas of how we make decisions and how we live.
Okay, thank you very much. And just one quick thing before we go on, which will probably be the last question, I'm afraid. So looking at after children with malignant diseases, leukemia and other cancers, taking consent for clinical trials, which most children are treated on, can be quite difficult. And I remember speaking to a single mum. The daughter was 13 and she was not paying any attention at all. She was doing something on a computer in the corner, and I was explaining it hopefully carefully and slowly about the clinical trial to the mum. And she was asking lots of questions, and eventually this child said, "Oh, Mum, it's a no-brainer, I've got to go on the trial," which was really helpful, actually. So she went on the trial and actually did extremely well. But on the other hand, we had a child who was under 16 who did not want to be treated. And it was accepted that he was Gillick competent. He knew exactly what the consequences were, and so he was not treated. His parents were distraught. But what was very difficult is the staff on the ward were also pretty distraught, actually. And we had the settlement services, but we had a chaplain on our team. We held a couple of meetings to talk through what was a very difficult situation, I said, not just for the family, which must have been almost intolerable, but for the people treating this particular patient. But for that patient, it was decided and it was the correct decision. But it's something that, something I've not forgotten, because it was hard. Right. So this may be the last question, it may not, it depends how much discussion we have. Should parents be allowed to genetically, they wouldn't be doing it themselves, but allow them to genetically modify embryos for non-medical trays?
Well, I think there's behind this in society is a rather simplistic view of how genetics works. And I'm not a geneticist, I'm not even a scientist, but I'm pretty certain it's all very much more complicated than one gene for one thing. Genetics is extremely complicated. It's extremely risky, but there are certain areas which are fairly clear where you can modify for health reasons, as far as I understand it. Other reasons, where it's much more uncertain what's going to happen. Are you going to experiment with people's lives? Have parents a right to say, I want more intelligent children? Well, a good way of getting more intelligent children is acting more intelligently towards them and maximising their doing it socially. I think there's been a lot of mythology around this area, and as the science has proceeded, it's become evident that it's more complex. But that's very much a layman's view of this, and so I would think that one should be very cautious about using about genetic manipulation. There are even people who think you can make people more moral by getting the right genes, and I think that's almost a contradiction in terms, I think.
Thank you. There has been quite a lot recently in the press about Huntington's chorea, which is a single gene disorder.
Yeah.
So, and that is obviously not a non-medical trait, it's a medical trait. And it's actually hugely exciting that that gene can be modified in vivo, so in the patient as they're actually living. And that, you can imagine, could at some point be taken further back so that it's changed at the embryonic stage or before the baby's born. And there are other disorders too. There's haemophilia, which is something which can also be genetically changed, sickle cell disease, a lot of diseases coming along. But for non-medical traits, my gut feeling is that that is not the right way to go, because there are so many diseases which need to be dealt with first before any thought about non-medical traits. So anyway, over to you guys.
So I'm not sure this is going to be a particularly scientific or moral answer, but like Angela, my gut instinct is no. I think in many ways diversity, differences, the lottery of life is interesting. And actually, I think, what happens if it went wrong? What happens if parents said, well, I'm going to, genetically modify my embryo so they have blue eyes and, whatever else, and then imagine that didn't materialise. What happens then? I worry about the slippery slope, and then what are we just then going to start? What if everybody wants the same traits? We're all going to look the same. What happens to diversity? What happens to tolerance? Does it introduce discrimination? So not particularly scientific, but my gut instinct is absolutely no.
I think doctors in the UK, by working in the NHS, are also all in touch with a kind of public health questions, because we're aware that we work with a finite resource, which is trying to meet the needs of the whole population. So I think for us, that question naturally gives rise to a feeling of, if we are doing modifying, if we are spending that time and attention, effort, let's spend it on improving health, not making sort of aesthetic choices about life. Equally, it feels sort of inevitable at the moment that people are going to pursue these lines of inquiry and innovation. And what will that mean? And like Kathy, history doesn't repeat itself, but we can learn lessons from history. And once we succumb to this kind of biological determinism of the way to have the best children is not to give them love and care and everything we can in life, but to kind of try and choose them. What's the shadow side to that? And do we become more intolerant of difference, more intolerant of disappointments we hold? But let's say it's not about genetic modification. Let's say it's about someone's having IVF, their eggs have been harvested, and we can now, in a really harm-free way, tell them, well, this egg is like this and this egg is like that. And you can make just a choice within this set without causing harm, without creating other eggs that would be. This is actually a pool that you can choose from. One can imagine that happening with technology that allows us to discern differences that may arise if either egg is fertilized. What I suspect is that we would find that the choices are a bit of a blind choice, that we begin to focus on one detail, not realizing that there are many others, and that one choice might be right in one way and yet wrong in another. And actually, the tyranny of choice becomes actually very hard. I'd rather almost not know. But just to reference Professor Thomas, that do read about the recent advance with Huntington's disease, because it's such a debilitating condition, such an awful, awful Shakespearean forecast to live with. And the promise of this gene therapy is really like one of the examples of like magic in our day. It's very, very exciting.
Thank you. Does anybody here think that it would be the right thing to do to genetically modify an embryo for non-medical trays? I think you're just yawning, we're not putting your hand up, are you? Okay, so everybody, we all agree that that's not a good plan just at the moment. Okay, so there is one last question, which isn't strictly ethical, but perhaps, well, I think probably all questions are, what are our opinions on AI's influence in medicine?
I wondered when that was
We
coming.
have 8 minutes. Who would like to start?
It's got a lot of promise for many things and a lot of dangers as well. I mean, the latest theory is that they'll get so intelligent that they'll decide they're better than human beings and get rid of us. But I mean, again, that's rather like the genetics hypothesis as well. I mean, it depends how we use it, and I think it's the trouble is that there's a lot of commercial interest in taking it as far as possible at the moment, and again, it's something that you have to. There are pros and cons. There are benefits in medicine, in practical benefits. That some AI things can do things better than humans because they're quicker. I mean, but the intelligence in a way is a bit of a misnomer. It's not. It's information processing that is done at a speed we couldn't hope to emulate, but it's not got any moral compass as far as I can see. It only has what you put into it.
I mean, it is interesting. I've Googled various things, and they come up with the AI answer. And sometimes it is absolute nonsense. And I know it's nonsense because I know that area. But if I Google how do I fix something on my computer, it tells me something, and I believe it must be true because I don't know very much about that area. So, there are things where you need, particularly with conundrums, medical conundrums, it does not know what it needs to know. But in other areas, for instance, as a hematologist, you look down a microscope, you have to recognize cells, and sometimes it can be very difficult picking out one cell compared with another. There are all sorts of features you look at, and it takes a long time to learn, many years to learn. And actually, if you had a computer that could, artificial intelligence could recognize these very fine features, that would probably be extremely helpful. But answering questions like this, I think it would be pretty useless. don't know, what do you think?
Yeah, I mean, I would agree entirely. I think there's definitely things that we could outsource that would make our jobs easier and free us up to do the more human tasks that AI will never be able to replace. I think there's no substitute for morality. That'll be very difficult to do artificially. And similarly, experience and wisdom. And sometimes, you know, you could have two patients that have exactly the same symptoms, and you could plug those symptoms, you know, in, get ChatGPT answer, what does it tell you? But actually your experience and looking at those individuals tells you that they may have two very different conditions. And I think that's what's going to be very difficult to replicate and should never be replaced. And there are certain things that should never be replaced. You don't want a robot or something that's not a human telling you that you've got a life-limiting condition or having to have a very nuanced discussion with you about treatment options and pros and cons. It doesn't necessarily have it won't have emotional intelligence. It can't pick up non-verbal cues that are so much part of how we communicate with patients. Is not just what they tell us, but actually the body language and how we can read that, how we read the dynamics and things like that. So I think has a place, but you know, as you've heard already, it's only going to be as good as the information that we give it and that we want it to do. And I think we should be very circumspect about what we want it to do.
It's such an interesting topic, and I think, you know, I'm a hard-working doctor. I'm quite arty-farty. I work relationally with patients, a lot of coaching in clinic, patients with long-term conditions, illness they didn't wish for, and yet they must craft a life of small steps in a journey to find ways of being a person with the problems they have. There's so many ways in which I can imagine AI being so helpful to me, so helpful to us in the hospital in an assistive way, whilst at the same time knowing that there's lots of kind of simulacra around AI sometimes, where at the moment the tools are not quite as good as they're made out to be. The first time I used ChatGPT to help me with some basically research assistance, it just hallucinated papers at me. And they were thematically correct, but there weren't real papers. I tried to look them up to download the PDFs. They didn't exist. And things like that still keep cropping up. But it's a huge potential advance. It is going to be transformational to the practice of medicine in your lifetimes. And one area I'm really interested in, because of my own background, I suppose, is of how we place trust in doctors, how we will place trust in kind of AI companions. Will it be that one day you have an AI companion that you sort of trust to know about you, and you come with it to your clinic, and you want it to ask questions of the doctor? There's a myriad of ways in which this will be really transformational, and I suspect we don't quite fully realize it yet. So that would be my kind of, if I could take a sabbatical right now, I'll do a sabbatical on how we can use AI, maybe not in the ways that are the big push at the moment, but in other assistive ways, such as someone who can kind of relate to an AI companion in between appointments with me.
Somebody put it like this: that AI doesn't know what it doesn't know. It only knows what you put into it. And I think that if one bears that in mind, the overblown claims for AI, let alone consciousness, I think you can get them in proportion. But I agree with but you know, there's a lot of benefit to come from it as well.
Okay, well, I think we have 1 minute left, which is probably enough time for me to say thank you so much for all of you for coming to the college. I hope you've enjoyed the visit. If you haven't been before, do come back. There's a nice exhibition about addiction, which is, covers addiction from like the 15th century through. I hope you've have a lot of food for thought over today's debate that we've had. We haven't got through all the questions, but quite a lot of them are related, and I hope that if you do have access still to the Slido questions, you can look at the ones we didn't get to and see if you actually have changed your opinion on potential answers or have some further ideas. Also, thank you so much for those who've joined us online. There are quite a lot of you, and that's allowed us to expand out with the confines of Scotland. And best of luck for all of you for the next stages in your career, school life first, and then hopefully university or whatever you decide to do. So thank you so much. Oh, and thank you to the panellists, obviously.